بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the chest lectures, and here we will deal with two final lectures in this sector, which one of them will be about the pleural pathology, and the second one will be on the chest wall lesions. And by the end of the chest wall lesions, I think we have covered most of the issues that are dealing with pulmonary parenchymal lesions, mediastinal pathology, as well as the pleura and the chest wall, and we have covered most of the related issues. Then after that, I think we will start in the sector of abdominal imaging after that, inshallah. Then the pleural pathology, we will handle these topics. Number one, pleural thickening and the pleural plaques, pleural calcification, pleural effusion, pleural emphysema, pneumothorax, bronchopleural fistula, benign pleural neoplasms, and finally the malignant neoplasms. We'll start first by the issue of the pleural plaques, which are usually formed of collagenous connective tissue, and there is an intimate relation between the pleural plaques and the asbestos exposure, as you all know. And this is seen in in up to 60% of workers with high exposure rate of asbestos. And you should know that most of the pleural plaques occur in the posterior and lateral aspects of the pleura, and this is in autopsy specimen showing the appearance of the pleural plaques. Then one of the important diagnostic landmarks for the detection of pleural plaques in the chest X-ray is to look for the surface of the diaphragm. And whenever you see calcified plaques on the surface of the diaphragm, you can explain most of the unexplainable opacities crossing the lung field. I'll give you an example. Here you can see a chest X-ray with multiple fluffy opacities scattered throughout both lung fields. Some of these opacities are relatively dense, suggesting the possibility of being calcified. And also you can see linear calcific shadows along the costal surface, suspecting that these are of pleural origin. But whenever you look to the surface of the diaphragm and you see these very clear calcified pleural plaques, you can easily assume that most of these shadows belong to the pleural calcification. And they are superimposed on the lung field because they are affecting the anterior costal pleura, the lateral, and the posterior costal pleura, of course. Then the pleural calcification are usually bilateral, unless they are the sequelae of a specific unilateral infection like TB, for example, and commonly they may be seen on the left side, and whenever they are bilateral, they are usually asymmetrical. Then whenever you have the CT scan, you can see the pleural plaques as areas or foci of relatively thickened pleura, which is not continuous but interrupted with normal pleura in between, and these plaques may be calcified and may be uncalcified. Then this is one of the clear-cut radiological finding of pleural plaques, and the clue here is the surface of the diaphragm. And here you can see dense calcified pleural plaques on the diaphragmatic surface bilaterally. Then you can easily explain these bizarre shadows crossing the lung fields which are simply representing calcified pleural plaques as well. Then the pleural plaques may be seen in the plain film or in the CT scan. And if you look here in this X-ray, and you see costal pleural thickening, and whenever the pleural thickening is continuous, and this is known as thickening. When it is discontinuous, we call these as plaques. Then pleural thickening along the costal pleura with obliteration of the costophrenic angle and some linear atelectatic bands related to the surface of the pleura. Then you can easily identify this, and you see that the pleura is relatively thickened and there is some subsegmental atelectasis, and you also see some linear bands projecting from the surface of the lesion, and this appearance is usually referred to as the hairy plaques. Then pleural thickening is continuous thickening of the pleural surface, and you can see this is the thickened pleura, and you can identify the thickened pleura because of the extrapleural fat and the air in the lung as well. Then this is a thin layer of thickened pleura, which usually does not indicate a specific disease, but is a mere radiological finding. Diffuse pleural thickening is usually of benign nature unless there are specific criteria I will explain in this lecture. Smooth and continuous pleural thickening extending over at least 25% of the chest wall, like you can see here, pleural thickening, and it is less common than pleural plaques and involve usually the visceral pleura. Pleural calcification and associated parenchymal pulmonary disease, as I have said before, in our country TB is common, and we usually look at the calcification of the pleura, calcification in the lung, calcification on the surface of empyema to point for the possibility of TB. And here is an extensive pleural plaques with calcification. You can see this is calcific plaque, and this is the larger one, this is a smaller one, and the larger one here. And also on the right side you can see some pleural effusion. You can also identify some basal consolidation or atelectasis. Another appearance of pleural plaques, calcified and uncalcified plaques. Here you can see this is the pleural calcification in a plaque, large plaque, and also here you can see calcific plaques. And in this example you can see larger calcified plaques and more or less non-uniform pleural thickening here, and there you can see also calcification as well. Then, as I have said, we usually suggest the possibility of tuberculosis whenever we see calcium in relation to the pleura or to the lung. But you know that asbestos plaques may also show some calcium, and other plaques secondary to any other disease may also show some calcification. Then we came to the pleural effusion, and the effusion means that you have fluid in the pleural cavity, and we can detect by imaging minor amount of fluid in the range of 15 to 50 milliliter, but using the chest x-ray you need about 200 milliliter of fluid to be detected in the frontal view, and about 75 milliliter of fluid to be detected in the lateral view. You know that the posterior costophrenic angle is more deep than the lateral costophrenic angle, and any fluid obliteration of the posterior costophrenic angle can be easily identified in the lateral view. While in the frontal view you need a lot of fluid in order to appear as blunting or obliteration of the costophrenic angle. Then whenever a pleural effusion is suspected, we used to do a lateral view. Then we may have what we call the decubitus view. We put the patient on the diseased side, and here is on the left side, and if there is some fluid underneath the diaphragm, it will trickle in the pleural space, as you can see here. And of course, this maneuver is not commonly used nowadays, and we use instead the ultrasound to detect minor pleural collections. There are a lot of causes for the pleural fluid, and also the content of the pleural space regarding the nature of the fluid itself, whether it is transudate, exudate, blood, chyle, cholesterol, and even urine. Then all these collections will appear as what we call the meniscus sign. When the costophrenic angle is obliterated, and you got what looks like the meniscus, and this meniscus has a concave upper border, and the lateral margin is raising towards the axilla. Then whenever you look to the chest X-ray and you see obliteration of the costophrenic angle, and instead of this meniscus sign, you see a convexity looking up. And this is not, of course, an effusion, and you suspect a mass. Then in children in particular, the pleural effusion has a specific configuration, which is known as the lamellar pleural effusion. Usually in the pediatric age group, the effusion extends along the lateral chest wall in a lamellar fashion, while in adults, the effusion should have the meniscus appearance. But if you see this lamellar effusion in an adult, then you should suspect that this effusion is encysted. And whenever you suspect an encysted effusion, except in the minor fissure, you should also suspect the possibility of being secondary infected. Then here is the chest X-ray of an adult, and you got an obliteration of the costophrenic angle and the convex inner margin with a lesion which is extending along the inner aspect of the chest wall, indicating that it is not of pulmonary origin, and this is an encysted pleural effusion. Whenever you diagnose encysted pleural effusion in an adult, you should suspect of being possibly infected as well, except in this type of effusion, which is encysted effusion in the minor fissure. And this is the classic diagnosis from the plain X-ray, and you look to an elliptical shape, fusiform, sharply marginated opacity centered at the minor fissure. And in the lateral view, you also see the same pathology, and this is an easy diagnosis which indicates an encysted effusion in the minor fissure. Then the effusion may be mild, may be moderate, may be severe. In all cases, it should show the meniscus sign with concave upper border, and the lateral margin is raising towards the axilla. As I have said, many causes are known for the pleural effusion, including congestive heart failure, and the parapneumonic effusions, post-traumatic, pulmonary embolism, tumors of the lung and the pleura, autoimmune diseases, and renal failure. Then in the CT scan, you see the fluid density in the pleural space, and this fluid density should not show any enhancing margin. And this is the simple bilateral pleural effusion on the left side. The effusion has extended into the fissure as well. But whenever you diagnose massive pleural effusion, and you should think of an underlying malignancy. And this is the massive unilateral pleural effusion obliterating the left hemithorax. And if you look carefully, and you can see a sclerotic lesion in the left seventh rib. Then let us look at the ribs. This is rib number 1, and this is 2, this is 3, 4, 5, 6, and 7. And here you can see the lesion. And this effusion was massive, as you can see, and the malignancy was suspected. And then further evaluation should be done in the form of a CT scan to detect the underlying pathology. And in this patient, you got massive left-sided pleural effusion with obliteration of the costophrenic angle, mass effect on the heart and the mediastinum, which are displaced to the opposite side. And the cause is pulmonary adenocarcinoma with pleural spread, which is obscured by the effusion. Then you cannot identify the lesion unless you have the CT scan. And sometimes, especially in the pediatric age group, you got this appearance where you see that the lung field is veiled or looks like the ground glass appearance. And if you ask the clinician, the technician, he may say that I radiographed this patient while being supine because I failed to put him in the erect position. Then effusion in the supine position will spread underneath the lung and results in veiling of the left hemisphorus. And this is homogeneous veiling where you can see the vascular markings of the lung, and you should think of this whenever you know that this radiograph was taken in the supine position. Then whenever you feel that, you should look to the erect one, and in the erect position you can see some air fluid level on the left side indicating the presence of hydropneumothorax. Then if you look to the chest x-ray, and I have explained this before, and you see that there is a big difference between the right and the left diaphragmatic copula. You know that the allowed difference between both copulae is from 1 to 3 centimeter. The right one is higher. Then if the height is more than 3 centimeter and the apex of the diaphragm is shifted laterally, you think of a subpulmonary effusion. And as I have said, we used to do this decubitus position in order to see the fluid coming from underneath the lung into the pleural space. But nowadays we use more commonly the ultrasound. And here the chest X-ray show almost no evidence of effusion except for minor blunting of this costophrenic angle. But by the ultrasound you can detect very subtle pleural collections as well as the collections inside the abdomen if they coexist. Then if you got an effusion and ascites in the same patient and you want to know which is effusion and which is ascites, then you have to identify the copula of the diaphragm. And this is the copula of the diaphragm. What is anterior to the copula is ascites. Anterior starts by the letter A, and ascites is also by the letter A. And the fluid which is posterior to the diaphragm is pleural effusion, and the pleura starts by the letter P and also the posterior saw. Then you should identify the copula of the diaphragm. The anterior fluid is ascites, the posterior fluid is effusion. And some of my colleagues say that whenever you see a fluid that is uplifting the diaphragm away from the spine, then you think of effusion. This is a sign also, and you can use both signs for diagnosis. Of course, if you have an MRI pleural effusion, you will see high signal in the T2 and the low signal in the T1, similar to any other fluid. Then how can you know that this fluid is free of infection or is secondary infected, for example? Then this is one of the signs, which is enhancement of the edge of the pleural collection. This is the pleural collection which is not infected. You got some pleural fluid of water density in the CT scan, no evidence of enhancement along the surfaces of the pleura. But here you see a fluid collection with enhancement of the margins of the collection and the compression of the adjacent lung as well. Then it is also known that whenever you got fluid, the CT density is in the range of 0 to 15 ounce field units, while if you get blood or pus, and then the attenuation value will raise about to about 30 ounce field units. Then the diagnosis of empyema is almost simple. Whenever you see a collection in the pleural cavity and you see enhancement of the margins of this collection, and if possible to detect some air loculi inside, and these are criteria which highly suggest the possibility of the fluid being infected. And you should be careful about the about reporting air loculi in the collection. If the patient had been subjected to an interventional techniques, the air loculi may be secondary to previous intervention, but the air loculi which are highly suggestive of infection are usually present without the history of previous doing biopsies, for example, or aspiration, or so and so. Then the pleural infected pleural collection passes into three phases or stages. The stage one is the exudative stage, where the pus accumulates, and this is the best stage for drainage. Then the fibrinovirulent stage with creation of pus pockets, which is a difficult stage for percutaneous drainage of these collections. Then the organizing stage, where pleural scarring may lead to lung entrapment and the development of calcium as well. Then this is the ultrasound of a fibrinolytic the fibrinovirulent pleural collection with multiple internal septations and pockets of pus, as you can see by this ultrasound. Then whenever you got an abscess in the lung, you can see enhancement of the margin and the air loculi within the abscess. Also, whenever you got an emphysema, you got enhancement of the margin, and you may got also air loculi. And the books usually say that the discrimination between emphysema and lung abscess is very important because of the difference in the management between both. Since emphysema is usually percutaneously drained, while the abscess is usually treated with antibiotics. Then one of the simplest ways to discriminate between both is the orientation of the lesion. If you see a lesion which is running parallel to the chest wall, I mean it has an anteroposterior diameter and a transverse diameter which are different, and this is of course is outside the lung, while you see a more or less spherical lesion with only single diameter, and this lesion should be located in the lung itself. A second issue where an extrapulmonary lesion should press or compress the underlying lung, resulting in some areas of atelectasis and some areas of consolidation. While the lung abscess is originating inside the lung parenchyma, it destroys the lung parenchyma in order to enlarge and occupy space for the abscess itself. Then emphysema is an oblong-shaped lesion, while an abscess is more or less a spherical lesion. Emphysema will compress the underlying lung, while the abscess has no compressed lung along its margin. Then this is an emphysema, and you can see the collection which is running parallel to the chest wall, and you see the collapsed lung underneath the pleura. And this of course is a weak sign, which is the angle of the lesion with the pleural surface or with the chest wall. If the angle is acute, you may assume that this is a pulmonary parenchymal lesion, and if the angle is obtuse, then you may assume that this is a pleural pathology. Then one of the important signs is known as the split pleura sign, and you got the collection between the parietal and the visceral pleura, and here is the sign which is known as the split pleura sign, which is one of the helpful signs to discriminate emphysema from the lung abscess. And this is the clearly seen split pleura sign, And without this sign, you can also diagnose this as an empyema because of the oblong shape of the lesion, and it runs parallel to the chest wall, and you can see also this sign as well. And this is an encysted empyema in the right lung base, and you can see the compressed lung parenchyma above the collection, and inside the collection you can also see air loculi together with the enhancing margin, classic of being infected. And this is also a good example for right-sided empyema, and you see the collection of pus with thick enhanced margin and multiple air loculi inside the lesion together with the compression of the lung against the border of the empyema. Then you remember that I have said that whenever you see calcium in the pleura, calcium in the lung, you may think of TB, especially in a country like my country, and where TB is relatively common. And if you see extensive pleural plaques like this, and you think of that these these calcifications are the sequelae of previous TB infection. And I have exposed this in the lecture of TB, and I give too many examples for the calcified and the uncalcified tuberculous lesions. And I also projected this case once, this case before, where you see an empyema with extensive calcification of the pleural surface along the margin of the empyema, suggestive of being of tuberculous etiology. And you remember that I have said that empyema, which is extending across the chest wall, coming into a subcutaneous location, it is known as empyema necessitans. And whenever you see calcium, you would suspect a tuberculous etiology. And many believe that empyema necessitans is usually the sequelae of TB, even without the presence of calcium. Then you see the extension of the empyema reaching the skin, forming a fistula connecting the lesion to the outside environment. And you see here, this is the collection in the pleural space with thickened enhanced margin, extension across the chest wall, forming a big subcutaneous abscess. And empyema is usually a collection of pus in the pleural space, and this empyema may contain air loculi, and the presence of air loculi usually supports the diagnosis of infection. There are three ways for air to develop inside the empyema. Number one, and the most common, is a iatrogenic way. You try to aspirate, you try to drain, then you introduce air loculi inside the empyema. The second way is the development of the bronchopleural fistula, communication between the pleural space and the bronchi. And the third way is infection with gas-forming organism, which is the rarest. Then the commonest is the sequelae of previous intervention. The second common is the development of the bronchopleural fistula, and the least one is the infection with gas-forming organism. Then the bronchopleural fistula is suspected whenever you see air with pus inside the pleural cavity, or air with pleural collection, what we call hydropneumothorax or hydrobiothorax. Pulmonary infections like necrotizing pneumonia, septic infarctions, and TB are common causes for the development of bronchopleural fistula. Iatrogenic, like post-pneumonectomy and thoracocentesis, positive pressure ventilation, post-traumatic, after penetrating injuries, for example, and in cases of malignancies, cavitating peripheral tumors or local recurrence of tumors after pneumonectomy. Then if you see an air fluid level like this, and you will call this as hydropneumothorax, and this hydropneumothorax may be maybe looked at the consequences of the development of the bronchopleural fistula. And here you see that there is a big collection on the left side with air fluid level, and the pleural enhancement is noted. You see here this enhancement, which is suspecting the inflammatory etiology of this collection, and the presence of air without the previous intervention is usually suggestive of a bronchopleural fistula. And after pneumonectomy, a bronchopleural fistula may be suspected if there is less fluid or more air in the operated hemithorax than expected. Usually, whenever you remove the lung, there may be some fluid and some air. But if air is too large than expected, you may suspect the development of bronchopleural fistula. Or if the ratio of air to fluid increases with time, this means that there is an air leak through a fistula into the pleural space, or the appearance of air in a fluid-filled hemithorax several months after pneumonectomy. This means that the fistula has been developed. Then, if you see an air fluid level in the pleural space, and you can see also the collapse of the lung compressed by this hydropneumothorax, and you think this hydropneumothorax is the sequelae of a bronchopleural fistula if no history of previous intervention is known. Then the issue of round atelectasis is one of the challenging issues in the chest radiology because of the fear of this lesion to be a malignant neoplasm. Then if you remember what I have said about the pleural plaques, and you get some plaques with an atelectatic part of the lung and multiple linear bands of atelectasis as well projecting from the inner surface, and this is what may be called like the comet tail appearance, and this is conclusive for the possibility of round atelectasis. Then if you look here, and you can see this is the pleural thickening, and this is the part of atelectasis in the lung, and you see the hairy or the linear bands of atelectasis representing the vessel and the bronchus, and this is known as round atelectasis. You remember that I have said if you have a peripheral pulmonary nodule with a speculated outer margin, you may suspect peripheral bronchogenic carcinoma, and anyone may feel that this is the speculated margin of a lesion, but whenever you see that these lines correspond to the vessels and the bronchus, and you got a localized pleural thickening adjacent to the lesion, also you can see some air bronchogram inside the lesion. All these are conclusions for the possibility of round atelectasis, together of course with the appreciable loss of volume in this particular area. And this is also a case of round atelectasis, and you can see it's hardly mistaken for the lung cancer. The diagnostic criteria include diffuse pleural thickening, which is very important, volume loss, which is very important also, and the comet tail sign, which is the radiating opacities from the inner surface of the lesion. When these criteria are fulfilled, no further examination is needed to exclude malignancy, like the CT-guided needle biopsy, for example. And this is an example of round atelectasis secondary to empyema. And you remember this example. This is an empyema with a round atelectasis here, and you can see the loss of volume, you can see air bronchogram, and you can see the linear radiating shadows from the inner surface of the lesion. Then we came to the pneumothorax, and the pneumothorax may be spontaneous or may have an underlying pathology, like the presence of asthma, chronic obstructive pulmonary airway disease, pulmonary infection, neoplasms, Marfan syndrome, and some patients with smoking cocaine, for example. Then this is the appearance of pneumothorax in the chest X-ray, and you got hypertranslucency of the affected hemithorax, absence of vascular lung markings in the translucency. And if you look carefully against the hilum, especially against the hilum, you will see the collapsed lung. And you should remember that the collapsed lung is not opaque unless it is totally collapsed. And you got this lung is subtotally collapsed, but it is still aerated, as you can see. Then whenever the pneumothorax is one of the conventional or ordinary pneumothorax, I mean not a tension pneumothorax, you got central mediastinum and the normal appearance of the diaphragmatic copula. But whenever you see that the pneumothorax is associated with depression of the diaphragm or flattening of the diaphragm and the contralateral shift of the mediastinum, then you are dealing with the case of tension pneumothorax. And here you can see some minimal shift of the mediastinum with subtotal collapse of the lung against the hilum and the depression of the ipsilateral diaphragm, suggestive of tension pneumothorax. And this is a classic case of tension pneumothorax. You've got total lung collapse against the hilum, hypertranslucent hemithorax, depression of the diaphragm, and the contralateral shift of the midline structures to the opposite side. And of course, minor amounts of pneumothorax are one of the tricks in the exams everywhere. And the clue for the presence of pneumothorax is to identify the pleural surface here. And if you look to the rest of the hemithorax, you cannot see any vascular markings in this area because there is here air only, and this is the pneumothorax and this is the pleural line. Then after insertion of an intercostal tube or a drainage tube, you can see hyperinflation or regression, somewhat regression of the pneumothorax. You see this is the pleural edge here, and still there is some air in the apex of the lung. Then spontaneous pneumothorax is the pneumothorax without an obvious cause, and this is a male 3 months, male infant 3 months old, with pneumothorax on the right side, collapse of the right lung. The mediastinum is central and the diaphragm is okay, and this is in ordinary pneumothorax. Here also you can see a pneumothorax with subtotal compression collapse of the lung. This is the air-filled pleural space. The mediastinum is central and the right side is okay. Actually, you don't need to have a CT scan to confirm the diagnosis of pneumothorax when it is evident in the plain X-ray, but sometimes you can see here that this is a good example by CT, and you see a space which is totally filled with air and the lung is collapsed here. And one of the big differentiating points here is to discriminate pneumothorax from bullous emphysema. And in the bullous emphysema, you should see some linear bands between the air-filled spaces, and these linear bands representing the minimal or the residual compressed lung parenchyma in between the emphysematous bulli. And this is the difference between pneumothorax, where no bands can be seen crossing the air, and the bullous emphysema. This is the case of pneumothorax on the right side, and you can see the pleural edge and you can see the fluid outside the pleural edge. Then actually this is one of the well-known complications whenever you try to insert a central venous line, and you may injure the apex of the lung, resulting in ipsilateral pneumothorax. And this is pneumothorax by the CT scan. You can see the air and you can see the collapsed lung. Iatrogenic pneumothorax is caused by the physician during surgery or during central line placement, as I have said. And traumatic pneumothorax may be the sequelae of rib fracture and injuries, penetrating injuries to the lung. And here you can see this is the pneumothorax, and the collapsed lung is seen here. And if you look carefully, there is shift of the mediastinum and the flattening of the diaphragm. Then you are dealing with a case of tension pneumothorax. And if the patient is in the supine position, you may have some difficulties for the diagnosis of pneumothorax, but here you can see that there are air and fluid as well, what we call the hydropneumothorax. Then we have emphasized the diagnosis of tension pneumothorax because this is a surgical emergency or a medical emergency, and you can is diagnosed by the presence of air in the pleural space, flattening of the ipsilateral diaphragm, and contralateral shift of the midline structures. And this is a tension pneumothorax in a child. You can see the air, you can see the collapsed lung, you can see the shift of the mediastinum, and you can see also the flattening of the diaphragm. Finally, we came to the pleural neoplasms, and the benign neoplasms are rare. And one of the known lesions is the pleural lipoma. And if you look in the chest x-ray, you cannot say that this is lipoma unless you have an evidence either from CT or MRI. And this is the CT scan of the same case showing a fat containing lesion which is based to the pleura. And in the T1 weighted image, you know that fat is bright, and in the T2 weighted image, the fat is less bright. And this is one of the uncommon benign pleural neoplasms, which is the pleural lipoma. But the malignant neoplasms are common, especially the mesothelioma, and the mesothelioma is a well-known disease in my country. This is a malignant lesion of the pleura, and it has a very strong association with asbestos exposure. And you know that about 7% of asbestos workers develop mesothelioma, and there may be a latent period between exposure and the development of the disease, which may range from 30 to 45 years. And the age incidence is about 50 to 70 years, and males, of course, are much more affected than females. Then the X-ray findings in cases of mesothelioma include unilateral pleural effusion. This is a pleural pathology usually associated with effusion, and the nodular pleural thickening. And in here, this is not the pleural thickening we have talked about, but here you got non-uniform nodular pleural thickening, which indicates the presence of masses in the pleura itself. Then the lesion may also affect the fissures, as you can see here. This is the nodular pleural thickening, totally encasing the lung, and also affecting the fissures as well. Then in order to confirm your diagnosis, you should have a CT scan, and sometimes we may have a biopsy to confirm the diagnosis. Then this is the chest X-ray and the follow-up study after 3 months. You can see the progression of the disease. The patient developed the nodular non-uniform pleural thickening, especially evident in the apex of the lung and along the costal surface of the pleura, obliterating the costophrenic angle associated with some pleural effusion. And if you look carefully to the diaphragmatic surface, you can see the calcified pleural plaques as well. But the CT is valuable here, and the diagnosis is usually easy from the CT scan by identifying these pleural masses. And you see the pleural thickening here is not uniform. Mild thickening, considerable thickening, and severe thickening. And the affection of the pleura involves all the surfaces of the pleura, the costal, the mediastinal, and the diaphragmatic pleura as well. Then any pleural pathology may be associated with pleural effusion, and this disease may be associated with metastatic lymphadenopathy. It may extend to the opposite pneumothorax, or may extend through the pleuroperitoneal recess into the abdomen. And here you can see nodular non-uniform thickening of the pleura in the mediastinal window, as well as in the lung window, as well as in the reconstructed coronal image. And you should remember that the pleural thickening is much more evident at the basis and at the costophrenic angles. And in this coronal image, you can also see the enlargement of mediastinal lymph nodes. You see here, this is a case of advanced pleural mesothelioma with severe thickening of the pleura. You see pleural masses totally encasing the lung, which is subtotally collapsed. And here you see a massive pleural effusion, and you cannot know what is underlying this effusion. You may suspect only malignancy, but malignancy may be in the lung, maybe in the mediastinum, and maybe in the pleura. And then the CT scan showed number one, nodular pleural thickening; number two, the presence of calcification within the thickened pleural masses; and number three, the presence of massive pleural effusion with compression and the shift of the mediastinum to the opposite side. And here is the mesothelioma by chest X-ray. Actually, it's an easy diagnosis by the chest X-ray, and it can be easily suspected on the basis of the presence of multiple non-uniform nodular pleural thickening encasing almost totally the lung, together with the presence of some pleural fluid. And as I have said, the diagnosis is usually confirmed after you have the CT scan, and then many times we usually have a biopsy from these lesions. Then mesothelioma, as I have said, may be associated with mediastinal lymphadenopathy, metastatic lymph nodes. As you can see here, these are multiple lymph nodes enlarged in the mediastinum, and this is diffuse non-uniform pleural thickening, diagnostic of mesothelioma. Other malignant pleural diseases include the metastasis and lymphoma. And the metastatic pleural disease is usually diagnosed whenever you know that the patient had a primary malignancy, or you can see the malignancy in the available radiological examination. The most common malignant lesion metastasizing to the pleura is, of course, the bronchogenic carcinoma, followed by the breast cancer, and 10% of cases secondary to lymphoma, and the remaining 30% are coming from other primary sites. Actually, in our country, we usually diagnose the pleural thickening and nodular masses in the pleura as the sequelae of mesothelioma until proved otherwise. But if we know that the patient is having a primary malignancy like renal cell carcinoma, for example, then you should diagnose these masses as metastatic from the non-primary malignancy. Then you see here, this patient is 80 years old with known thyroid cancer. And if you look to the chest X-ray, you can see the nodular thickening of the pleura bilaterally and obliteration of the costophrenic angle due to the presence of pleural effusion. Then if you have the CT scan, and you can see clearly the thickened pleura encasing the lung, nodular pleural thickening, which is bilateral here. And you remember that mesothelioma is usually a unilateral disease. Then whenever you know that the patient had a non-primary malignancy, you should suspect the pleural pathology as metastasis. But actually, if we don't know that the patient had a non-primary malignancy, we think of particularly mesothelioma, and we resort to biopsy in order to confirm the diagnosis and to know the underlying pathology. Then pleural lymphoma is also known and is seen in about 10% of the cases are usually secondary to pleural lymphoma. But actually here you can see diffuse pleural thickening, and it is bilateral, and you can see here also affecting the diaphragmatic surface of the pleura, but you cannot be sure that this is lymphoma unless you know that the patient is known to be a lymphoma patient, or you see other stigmata of lymphoma in the body, like focal lesions in the spleen, for example. Then finally, the chest radiography is the imaging modality of a chest as an initial investigation in cases of pleural disease. And ultrasound is gaining much more acceptance today for evaluation of chest lesions, particularly in the pleura, and lesions which are very close to the chest wall. but you know that CT is the superior imaging modality for evaluation of most of the thoracic pathologies, including the pleural diseases as well, and MRI as well as the nuclear medicine may have a role in this investigation. Walhamdulillahi Rabbil Alameen.